Today let's see about disease of conjunctiva. Conjunctiva is translucent mucous membrane which lines the posterior surface of the eyelids and anterior aspect of the eye wall. The name conjunctiva has been given to this mucous membrane owing to the fact that it joins the eyeball to lids. It stretches from lid margin to limbus and encloses a complex space called conjunctival sac. Parts of conjunctiva: palpebral conjunctiva and bulbar conjunctiva. Palpebral conjunctiva. Palpebral conjunctiva, it lines the lids and can be subdivided into marginal, tarsal and orbital conjunctiva. Marginal conjunctiva extends from lid margin to about 2 mm on the back of the lid up to a shallow groove, sulcus subtarsalis. It is actually a transitional zone between skin and conjunctiva proper. Tarsal conjunctiva is thin, transparent and highly vascular. It is firmly adherent to whole tarsal plate in the upper lid. In the lower lid, it is adherent to only half width of the tarsus. The tarsal glands are seen through its yellow streaks. Orbital part of palpebral conjunctiva lies loose between tarsal plate and fornix. Bulbar conjunctiva, it is thin, transparent and lies loose with the underlying structures and thus can be moved easily. It is separated from antisclera by episcleral tissue and Tenon's capsule. This is a diagram. This is lacrimal gland, glands of Cauchy, superior fornix, glands of Mons, glands of Wolfring, Meibomian glands, glands of Gis, glands of Moll, glands of Wolfring and bulbar conjunctiva. This one is bulbar conjunctiva. This one is tarsal conjunctiva. This is inferior fornix. This is superior fornix. And these are glands of Cauchy. A 3 mm ridge of bulbar conjunctiva around the cornea is limbal conjunctiva. In the area of limbus, the conjunctiva, Tenon's capsule and episcleral tissue are fused into a dense tissue which is strongly adherent to underlying corneoscleral junction. At the limbus, the epithelium of conjunctiva becomes continuous with that of cornea. Conjunctival fornix. It is a continuous circular cul-de-sac which is broken only on medial side by caruncle and plica terminalis. Conjunctival phonics joins the bulbar conjunctiva with palpebral conjunctiva. It can be subdivided into superior, inferior and medial lateral fornixes. Structure of conjunctiva. Epithelium. This is a 2 to 5 layered non-keratinized epithelium. It also contains goblet cells which constitute about 10% of the epithelium. The layer of epithelial cells in conjunctiva varies from region to region. Epithelium, adenoid layer, fibrous layer. Superior fornix, inferior fornix, upper tarsal conjunctiva, lower tarsal conjunctiva, bulbar conjunctiva, limbal conjunctiva and bulbar conjunctiva, limbal conjunctiva and marginal conjunctiva are parts of palpebral conjunctiva. Marginal, tarsal and orbital are part of palpebral conjunctiva and bulbar is separate. This is corneal epithelium. Marginal conjunctiva is 5 layered stratified squamous epithelium. Tarsal conjunctiva is 2 layered epithelium. And fornix and bulbar have 3 layered epithelium, a superficial layer of cylindrical cells, middle layer of polyhedral cells, deep layer of cuboid cells. Limbal conjunctiva has again many layered stratified squamous epithelium. Limbal stem cells are present in basal layer of this part. Adenoid layer. It is also called lymphoid layer and consists of fine connective tissue reticulum, in the meshes of which lie lymphocytes. This layer is most developed in fornices. It is not present since birth but develops after 3 to 4 months of life. For this reason, congenital inflammation in an infant does not produce follicular reaction. Fibrous layer. It consists of meshwork of collagen and elastic fibers. It is thicker than the adenoid layer except in the region of tarsal conjunctiva where it is very thin. This layer contains vessels and nerves of conjunctiva. It blends with underlying Tenon's capsule in the region of bulbar conjunctiva. Glands of conjunctiva. Mucin secretory glands, accessory lacrimal. Mucin secretory glands are goblet cells, crypts of Henle, glands of Mons. Axillary lacrimal glands of Grassi, present in subconjunctival connective tissue of fornices, about 42 in upper and 8 in lower. Glands of Wolfring, present along the upper border of superior tarsus and along the lower border of inferior tarsus. Plica seminoranis. It is a pinkish crescentic fold of conjunctiva present in the medial canthus. Its lateral free border is concave. It is a vestigial structure in human and represents the nictitating membrane of the lower animals. Caruncle. Caruncle is a small white pinkish mass situated in the inner canthus, just medial to the plica seminoris. In reality, it is a piece of modified skin and so is covered by stratified squamous epithelium. Blood supply of conjunctiva. Arteries, peripheral arterial arcade of eye, marginal arcade of eye, eyelid, anterior ciliary arteries. Palpebral conjunctiva fornices are supplied by branches from peripheral and marginal arterial arcades of eyelids. Bulbar conjunctiva is supplied by two sets of vessels, posterior conjunctival arteries, which are branches from arterial arcades of eyelids, anterior conjunctival arteries, which are branches of anterior ciliary artery. Terminal branches of posterior conjunctival arteries anastomose with anterior conjunctival arteries to form pericorneal plexus. Veins. Veins from the conjunctiva drain into venous plexus of eyelids, some around the cornea into anterior ciliary vessels. Lymphatics of conjunctiva are arranged in two layers, a superficial and a deep. Lymphatics from the lateral side drain into pre-auricular lymph nodes, and those from the middle side into submandibular lymph nodes. Nerve supply of conjunctiva. A circumcorneal zone of conjunctiva is supplied by branches from long ciliary nerves which supply the cornea. Blood supply of conjunctiva. Posterior conjunctival artery, anterior ciliary artery, circulus major, circulus minor, peripheral arcade, descending branch, ascending branch, marginal arcade, subconjunctival plexus. Types of inflammation of rest of conjunctiva sublateral branches from lacrimal, infratracheal, supratracheal, supraorbital, frontal nerves. Inflammation of conjunctiva. Types of conjunctivitis: infective conjunctivitis, bacterial conjunctivitis, in bacterial conjunctivitis, acute bacterial, hyperacute, chronic, angular, chlamydial conjunctivitis, trachoma, adult incision, neonatal, viral conjunctivitis, adenovirus, enterovirus, molluscum contagiosum, herpes simplex virus, etc. Ophthalmia neonatum, granulomatous conjunctivitis, perinode ocular glandular syndrome, allergic conjunctivitis, simple allergic conjunctivitis, hay fever conjunctivitis, seasonal allergic, perennial allergic, vernal keratoconjunctivitis, atopic keratoconjunctivitis, giant papillary conjunctivitis, phyllectenular conjunctivitis, contact dermoconjunctivitis, cicatricial conjunctivitis, ocular mucous membrane pemphigoid, Stevens Johnson syndrome, toxic epidermal necrolysis and secondary cicatricial conjunctivitis. Toxic conjunctivitis. Infective conjunctivitis are commonest variety. This is in fact the conjunctiva has been provided with a natural protective mechanism in the form of low temperature due to exposure of eyelids, physical protection by eyelids, flushing action of tears, antibacterial activity by lysozymes and humoral protection by tear immunoglobulins. Bacterial conjunctivitis. There has occurred a relative decrease in incidence of bacterial conjunctivitis in general, those caused by gonococcus and Corynebacterium diphtheria in particular. However, in developing countries, it still continues to be commonest type of conjunctivitis. It can occur as sporadic and epidemic cases. Etiology: predisposing factors and causative organ. Predisposing factors are bacterial conjunctivitis or epidemic forms, flies, poor hygienic condition. Predisposing factors for epidemic forms of conjunctivitis are flies, poor hygiene, hot dry climate, poor sanitation, dirty habits, etc. Causative organs: Staphylococcus aureus, Staphylococcus epidermidis, and it can produce blepharoconjunctivitis. Both can produce blepharoconjunctivitis. Streptococcus pneumonia produce acute conjunctivitis, usually associated with petechial hemorrhages. It's a self-limiting and occurs in 9 to 10 days. Streptococcus pyogenes is virulent, usually produce pseudomembranous conjunctivitis. Haemophilus influenza. It classically causes epidemics of mucopurulent conjunctivitis known as red eye, especially in semi-tropical countries. Moraxella lacunata. is most common cause of angular conjunctivitis and angular peripheral conjunctivitis. Pseudomonas pyocinea is a virulent organism which readily invades the cornea. Neisseria cornea typically produce acute prolonged conjunctivitis in adults and ophthalmia neonatal and newborn. Neisseria meninges produce mucopurulent conjunctivitis. Corn-bitten diphtheria causes acute membrane conjunctivitis. Such infections are not known nowadays. Mode of infection: exogenous spread directly through close contact as airborne infection or waterborne infection, vector transmission, material transfer, etc. Local spread may occur from neighborhood sectors such as infected lacrimal sac, lids, sinus, pharynx, etc. Endogenous infection may occur very rarely through blood, gonococcal, meningococcal infections. Pathology: pathological changes of bacterial conjunctivitis consist of vascular response, cellular response, conjunctival tissue response, conjunctival discharge, etc. Vascular response: it is caused by congestion and increased permeability of conjunctival vessels associated with proliferation of capillaries. Cellular response: it is in the form of exudation of polymorphonuclear cells and other inflammatory cells into substantia propria of conjunctiva as well as conjunctival tract. Conjunctival tissue response: conjunctival becomes edematous, the superficial epithelial cell degenerate, become loose and even desquamate. There occurs proliferation of basal layers of conjunctival epithelium and increase in number of mucin secreting goblet cells. Conjunctival discharge: it consists of tear, mucus, inflammatory cell, desquamated epithelial cells, fibrin and bacteria. If the inflammation is very severe, diabetes of red blood cell may occur and discharge may become blood stained. Clinical types of bacterial conjunctivitis: acute, hyperacute, chronic, angular. Acute conjunctivitis is characterized by marked conjunctival hyperemia, mucopurulent discharge from eye. So clinically it is called acute mucopurulent conjunctivitis. It is the most common type of bacterial conjunctivitis. Its common cause are Staphylococcus aureus, Koch weeks, Bacillus, Pneumococcus, Streptococcus, etc. Clinical features: symptoms: discomfort, foreign body redness, blurring, redness of sudden onset are the usual presenting symptoms. Mild photophobia, difficulty to tolerate, mucopurulent discharge from eyes, sticking together of lid margins with discharge during sleep, slight blurring of vision due to mucus flakes in front of cornea, colored halos may be complained by some patients due to prismatic effect of mucus present. Signs: flakes of mucopus seen in fornices, canthi and lid margin as critical sign. Signs of acute mucopurulent conjunctivitis: flakes of mucopus seen. Conjunctival congestion, which is more marked by in palpebral conjunctiva, fornices and peripheral part of bulbar conjunctiva, giving the appearance of fiery red eye. Chemosis. Will continue. Chemosis, that is swelling of conjunctiva. Papullae of fine type may be seen. Petechial hemorrhage are seen when causative aggregates is pneumococcus. Cilia are usually matted together with yellow cross. Eyelids may slightly be odematous. Clinical course: mucopurulent conjunctivitis is usually bilateral, although one eye may become affected 1 to 2 days before other. The disease usually reaches its height in 3 to 4 days. If untreated, in mild cases, the infection may overcome and the condition is cured in 10 to 15 days. Or it may pass to less intense form, chronic cataract conjunctivitis. Complications: occasionally the disease may be complicated by superficial punctate epitheliopathy, marginal corneal ulceration, superficial keratitis, blepharitis or dacrocystitis. DD, differential diagnosis from other causes of acute red eye. We will see in future. From other types of conjunctivitis, it is made out from typical clinical feature of disease and is confirmed by congenital etiology given in table. Treatment: topical antibiotics are given to control infection constitute the main treatment of acute bacterial conjunctivitis. Ideally, the antibody should be selected after culture and sensitive test, but in practice it is difficult. However, in routine, most of the patients respond well to broad spectrum antibiotics. Therefore, treatment may be started with chloramphenicol 1%, gentamicin 0.3%, tobramycin 0.3%, freomycin 0.3%, premicin, eye drops 3 to 4 early in day. An ointment should be used at night. Will not only provide antibiotic cover but also help to reduce the early morning sickness. If the patient does not respond to these antibiotics, then quinolone antibiotics should be given. Ciprofloxacin, ofloxacin, garifloxacin, moxifloxacin may be used. Irrigation of conjunctivitis with sterile warm saline once or twice a day will help by removing deleterious material. Frequent eye wash is advocated, is however contraindicated. It will wash away lysozyme, other protective proteins present in the tears. Dark goggles should be used to prevent photophobia. No bandage should be applied in patients with mucopurulent conjunctivitis. Exposed to air keeps the temperature of conjunctival cul-de-sac low, which inhibits the bacterial growth. While after bandaging, conjunctivitis is converted into incubator, thus infection flares to a severe degree within 24 hours. Further bandaging away will also prevent the escape of discharge. No steroids should be applied, otherwise infection will flare up and bacterial corneal ulcer may develop. Anti-inflammatory analgesic drugs may be given orally for 2 to 3 days to provide symptomatic relief from mild pain, especially in sensitive patients. Hyperacute bacterial conjunctivitis. Hyperacute bacterial conjunctivitis, also known as acute purulent conjunctivitis or acute bluenuria. It's characterized by violent inflammatory response. It occurs in two forms: adult purulent conjunctivitis, ophthalmia neonatum, and newborn. Hyperacute conjunctivitis of adults. Etiology: the disease affects adults, predominantly males. Gonococcal infection directly spreads from genitals to eye. Onset is hyperacute. Symptoms: pain, purulent discharge, which is copious, swelling of eyelids, which is usually marked. Signs: eyelids are tense, swollen, tenderness is marked, discharge is thick, purulent, copious, trickling down the cheeks. Conjunctiva shows marked chemosis, congestion, and papillae giving bright red velvety appearance. Frequently, a pseudomembrane may be seen on conjunctival surface. Hyperacute conjunctivitis and pseudomembranous conjunctivitis. So, pseudomembrane is formed. Preauricular lymph nodes are usually enlarged and tender. Complication: corneal involvement is quite frequent as gonococcus can invade the normal cornea through intact epithelium. It may occur in the form of diffuse haze, edema, central necrosis, corneal ulceration, or even perforation. Iridocyclitis may also occur, but it is not as common as corneal involvement. Systemic complications, though rare, include gonorrhea, arthritis, endocarditis, septicemia, etc. Treatment: systemic therapy is far more critical than topical therapy for infection caused by Neisseria gonorrhea. Any of the following regimens can be adopted. Third generation cephalosporin such as cefoxitim 1 gram, cefotaxime 500 mg, IV QID, ceftriaxone 1 gram IM QID, all for 5 days should be preferred treatment. Quinolones such as norfloxacin 1.2 gram orally QID for 5 days, spectinomycin 2 gram IM for 3 days may be used alternatively. It should be followed for 1 week course of either doxycycline 100 mg BID or erythromycin 250 to 500 mg orally QID. Topical antibiotic therapy. It is presently recommended includes ofloxacin, ciprofloxacin, tobramycin eye drops, bacitracin, erythromycin ointment every 2 hours for the first 2 to 3 days and then 5 times daily for 7 days. Irrigation of eye. Frequently sterile saline is very therapeutic in washing away infected debris. Other general measures: topical atropine to be instilled if cornea is involved. Chronic bacterial conjunctivitis. Chronic bacterial conjunctivitis, also known as chronic catarrhal conjunctivitis, simple chronic conjunctivitis. It is characterized by mild catarrhal inflammation of conjunctiva. Etiology: predisposing factors, causative organism, and source of mode of infection. Predisposing factors: exposure to dust, smoke, chemical deterrents. Local cause of irritation such as trichiasis, concretions, foreign bodies, seborrheic scales, etc. Eye strain due to refractive errors, phorias, or convergent insufficiency, abuse of alcohol, insomnia, etc. Causative organism: Staphylococcus aureus, gram-negative rods such as Proteus mirabilis, Klebsiella pneumoniae, E. coli, Moraxella lacnata, etc. Source and mode of infection: as continuation of acute mucopurulent conjunctivitis when untreated or partially treated, as chronic infection from associated chronic dacrocystitis, chronic rhinitis, or chronic upper respiratory cataract, as a mild exogenous infection which results from direct contact, airborne material transfer of infection. Clinical features: symptoms of simple chronic conjunctivitis include burning and grittiness of eye, mild chronic redness in eye, difficulty in keeping the eyes open, mild mucoid discharge, watering off and on in often accompanied feeling of sleepiness and tiredness in eye. Signs: grossly the eyes look normal, but careful examination may reveal following signs: congestion of posterior conjunctival vessels, mild papillary hypertrophy, of palpebral conjunctiva, sticky look of surface of conjunctiva, lid margin may be congested. Treatment: eliminate predisposing factors when associated. Topical antibiotics such as chloramphenicol, tobramycin, gentamicin should be used 3 to 4 times a day for about 2 weeks to eliminate the mild chronic infection. Astringent eye drops such as zinc boric acid drops provide symptomatic relief. Angular bacterial conjunctivitis: it is a type of chronic conjunctivitis characterized by mild grade inflammation confined to conjunctiva and lid margin near the angles, associated with maceration of the surrounding skin. Etiology: predisposing factors are same as for simple chronic conjunctivitis. Causative organism: Moraxella axenfeld is the commonest causative organism. They are placed end to end, so the disease is diplobacillary conjunctivitis. Rarely, staphylococci may also cause angular conjunctivitis. Source of infection: usually nasal cavity. Mode of infection: infection transmitted from nasal cavity to eyes by contaminated fingers or handkerchief. Pathology: the causative organism, that is Bacillus, produces a proteolytic enzyme which acts by macerating the epithelium. This proteolytic enzyme collects at angles by action of tears and thus macerates the epithelium of conjunctiva, lid margin and skin surrounding angles of eye. The maceration is followed by vascular cellular responses in form of mild grade chronic inflammation. Skin may show eczematous changes. Clinical features: irritation, burning sensation and feeling of discomfort in eye. History of collection of dirty white foamy discharge of angles at angles. Redness in angles of eye. Signs: hyperemia of bulbar conjunctiva near canthi, hyperemia of lid margin near angles, excoriation of skin around the angles. Foamy mucopollen discharge at the angles is usually present. Treatment: prophylaxis include nasal infection, good personal hygiene. Curative treatment: oxytetracycline zinc lotion should be instilled daytime and zinc oxide ointment at bedtime inhibits proteolytic ferment, thus helps in reducing macerated. And for chlamydial, we will see the differentiating features of common types of conjunctivitis. Congestion: in particular it is marked, viral moderate, allergic mild to moderate, chlamydial moderate. Chemosis: subconjunctival hemorrhage, discharge purulent or mucopurulent, watery, ropey watery, mucopurulent. Papillae present or absent. Follicles, pseudomembrane. Cytology features: neutrophils are present, pox, herpes not present. Chlamydial conjunctivitis: chlamydia lie midway between bacteria and virus, sharing some features of both. Chlamydia combined with PLT group, Psittacosis, lymphogranuloma venereum, Trachomatis group. Life cycle of chlamydia: the infective particle invades the cytoplasm of epithelial cells, where it swells up and forms initial body. The initial bodies rapidly divide into elementary bodies embedded in glycogen matrix, which are liberated when the cells burst. Then the elementary bodies infect other cells, where the whole cycle is repeated. Trachoma is a chronic keratoconjunctivitis, primarily affecting the superficial epithelium of conjunctiva and cornea simultaneously. It is characterized by a mixed follicular and papular response of conjunctival tissue. It is still one of the leading causes of preventable blindness in the world. The word trachoma comes from Greek, means rough. Etiology: causative organism. The trick agents: Trachoma causative Bedsonian organism. The chlamydial trachomatis belong in the Psittacosis lymphogranuloma trachoma group. The organism is epitheliotropic and produces intracytoplasmic inclusion bodies called HB, Halbersteder Provozac bodies. Presently, 11 serotypes of chlamydia have been identified using microimmunofluorescence A, B, A, C, D, E, F, G, H, J and K. Serotypes A, B, A, C are associated with hyperendemic trachoma. Serotypes D and K are associated with inclusion conjunctivitis. Predisposing factors: age, sex, race, climate, socioeconomic status, environmental factors. is usually contracted during infancy and early childhood. Chlamydia species C. Trachomatis trick agent, C. Lymphogranulomatis, C. psittacosis. Serotypes A, B, B, A, C, D and K also belongs to same. L1, L2, L3 also belongs to lymphogranuloma venereum conjunctivitis, genitals to eye transmission. And A, B, B, A, C hyperendemic trachoma is transmitted eye to eye. Paratrachoma and adult incision conjunction. D to K, genitals to eye. Modes of infection: direct spread, vector transmission, material transfer. Direct spread of infection may occur through contact by airborne or waterborne modes. Vector transmission is common through flies. Material transfer plays an important role. It's transfer from doctor, nurses, contaminated animals, etc. Kerchiefs, etc. Handkerchief, towel, etc. Bedding, etc. Prevalence: it's prevalent in North Africa, Middle East, certain regions, Southeast Asia, etc. There are about 150 million cases with active trachoma and about 30 million having trichiasis. Clinical feature have been described in two phases. Phase of active trachoma usually occurs during childhood due to active chlamydial infection. Incubation period of active trachoma varies from 5 to 22 days. Onset of disease usually inside is. However, rarely it may present in acute form. Symptoms of active trachoma are determined by absence or presence of secondary bacterial infection. In the absence of secondary infection, a pure trachoma is characterized by following symptoms: mild foreign body sensation, occasional lacrimation, slight sickness, stickiness of lids, scanty mucus discharge. Conjunctival signs: congestion of upper tarsal and fornical conjunctiva. Congenital follicles look like boiled sago grains are commonly seen on upper tarsal conjunctiva and fornix, but may also present in lower fornix, plica seminalis and caruncle. Structure of follicles: papilla, follicle, congestion, panas, Ebert's follicle. Follicles are formed due to scattered aggregation of lymphocytes and other cells in adenoid layer. Central part of each follicle is made up of mononuclear histiocytes, few lymphocytes, and large multinuclear cells called Leber cells. The cortical part is made up of a zone of lymphocytes showing active proliferation. Blood vessels are present in most peripheral part. In later stages, signs of necrosis are also seen. Presence of Leber cells and signs of necrosis differentiate trachoma follicles from follicles of other forms of follicular conjunctivitis. Trachomatous inflammation follicle. Papillary hyperplasia. Papillae are reddish, flat-topped, raised areas which give red and velvety appearance to tarsal conjunctiva. Each papilla consists of central core of numerous dilated blood vessels surrounded by lymphocytes and covered by hypertrophic epithelium. Corneal signs. Superficial characteristics: Herbert follicles refers to type of follicle present in the limbal area. This histology is similar to conjunctival follicles. Progressive venous, that is infiltration of cornea associated with vascularization seen in upper part. The vessels are superficial and lie between epithelium and Bowman's membrane. Later on, Bowman's membrane is also destroyed. Panas is active trachoma. In active trachoma, it is progressive, in which infiltration of cornea is ahead of vascularization. Corneal ulcer may sometimes develop at advancing edge of panas. Such ulcers are usually shallow, which may become chronic and indolent. Phase of cicatricial trachoma. Cicatricial phase of trachoma manifests in middle age. It results due to continued mild grade chronic inflammation. In fact, recurrent infection elicits chronic immune response consisting of cell-mediated delayed hypersensitivity reaction to intermittent presence of chlamydial antigen. The end stage of cicatricial trachoma is also referred to as sequel trachoma. This phase is characterized by following characters: congenital sign, congenital scarring which may be irregular, star-shaped or linear. Present in sulcus subtarsal is called arch line. Concretions are hard-looking whitish deposits varying from pinpoint to 2 mm in size. These are not calcareous deposits but are formed due to accumulation of dead epithelial cells and inspissated mucus in the depressions called glands of Henle. Other congenital sequelae include concretion, pseudocysts, xerosis, symblypharon, trachomatous scarring. concretions in upper palpable conjunctiva. Trachomatis tracheasis, Trachomatis Herbert's pills, Trachomatis corneal opacity, corneal sign regressive panus, panus siccus, vessels extend a short distance beyond the area of infiltration. Herbert's pits are oval circular pit scars. Corneal opacity may be present in upper part. It may extend down and involve papillary area. It is the end result of trachomatis corneal lesion. Other corneal sequelae may cause corneal ectasia, corneal cirrhosis, total corneal panus. Lid signs. Sequelae in the lids may be trichiasis, entropion, tylosis, ptosis, medrosis, ankyloblepharon. Lacrimal apparatus sequelae may be chronic dacryocystitis, chronic dacroadenitis, graining of trachoma. Stage 1, 2, Stage 3, Stage 4. Stage 1 incipient trachoma, stage of infiltration. It is characterized by hyperemia, palpable conjunctiva and immature follicles. Stage 2, it is characterized by appearance of mature follicles, papillae, progressive corneal panus. Stage 3, it includes obvious scarring of palpable conjunctiva. Stage 4, disease is quite uncured but sequelae due to cicatrization gives rise to symptoms. Trachomatis inflammation follicular. It is the stage of active trachoma with predominantly follicular inflammation. To diagnose the stage, at least 5 or more follicles must be present in the upper tarsal conjunctiva. Trachomatis inflammation intense. This stage is diagnosed when pronounced inflammatory thickening of upper tarsal conjunctiva obscures more than half of normal deep vessels. Trachomatis scarring. The stage is diagnosed by the presence of scarring in tarsal conjunctiva. These scars are easily visible at whites, bands or sheets in tarsal conjunctiva. Trachomatis tracheasis is labeled when at least one eyelash rubs the eyeball. Evidence of recent removal or of interned eyelashes should also be graded as trachomatis tracheasis. Corneal opacity. The stage is labeled when easily visible corneal opacity present over the pupil. That sign refers to corneal scarring that is so dense that at least part of pupil margin is blurred when seen through opacity. The definition is intended to detect corneal opacities that cause significant vision impairment. Complications. Only complication corneal ulcer, which may occur due to rubbing by concretions or tracheasis which is superimposed bacterial infection. Diagnosis. Clinical diagnosis. It is made from typical signs. Clinical grading of each case should be done as per WHO into TF, TA, TS, TT or CO. Lab diagnosis. Congenital cytology, detection of inclusion body, enzyme linked immunosorbent assay ELISA, poly-PCR, isolation of chlamydia is possibly yolk sac inoculation method. Serotyping trick agents done by detecting specific antibodies using micro-immunofluorescence method. Direct monoclonal fluorescence antibody microscope of conjunctival smear is rapid and inexpensive. Differential diagnosis. Trachoma with follicular epidemic must be differentiated from acute adenoviral follicular conjunctivitis. Distribution of follicles in trachoma is mainly in the upper palpable conjunctiva of upper fornix, while in EKC, epidemic keratoconjunctivitis, lower palpable conjunctiva and lower fornix is primarily involved. Associated signs of papilla, panus are characteristics of trachoma. Laboratory diagnosis of trachoma helps in differentiation of clinically indistinguishable cases. Trachoma with predominantly papillary hypertrophy needs to be differentiated from palpable form spring-catter as follows. Papillae are large in size. Usually there is typical cobblestone arrangement in spring-catter. pH of tears is usually alkaline in spring-catter, while in trachoma it is acidic. Discharge is ropey in spring-catter. Follicle in the panus may also be present in trachoma. Conjunctival cytology and other laboratory tests for trachoma usually help in diagnosing clinical indistinguishable cases. Management of trachoma should involve curative as well as prophylactic measures. Treatment of active trachoma. Antibodies for treatment of active trachoma may be given locally or systemically, but topical treatment is preferred. It is cheaper. There is no risk of systemic side effects. Local antibodies are also effective against bacterial conjunctivitis, which may associate with trachoma. Therapeutic regimes include tetracycline, erythromycin, sulfacetamide, eye drops 3 times a day, along with 1% tetracycline eye ointment at bedtime. Systemic therapy regimes: azithromycin 20 mg per kg body weight up to maximum 1 gram stat or 250 mg OD into 4 days. It is presently considered as the first drug of choice, strain of drug of choice. Tetracycline or erythromycin 250 mg orally 4 times a day for 3 to 4 weeks. Doxycycline 100 mg orally twice daily for 3 to 4 weeks. Combined topical and systemic therapy regime. Tetracycline 1% or erythromycin IR 4 times a day for 6 weeks. Treatment of trachoma sequel. Concretion should be removed with hypodermic needle. Trichiasis may be treated by epilation, electrolysis, cryolysis. Cicatricial entrophion should be corrected surgically. Conjunctival cirrhosis should be treated by artificial tears. Safe strategy: surgery, antibiotic use, facial hygiene, environmental changes. Environmental changes, primordial prevention. Flies, other fomites are common cause of spread of trachoma. So environmental sensation will constitute the primordial prevention for trachoma. Recommended environmental sanitation measures include provision of water latrines, good water supply to reduce flies, improve washing habits, effuse dumps, sprays to control flies, animal pens away from human household, health education to improve personal environmental hygiene. Facial hygiene. Facial hygiene critical measure for primary prevention of trachoma should include frequent face wash with clean water to eliminate the potentially infectious ocular secretions. Avoidance of common use of towel, handkerchiefs, Surma rods are important facial hygiene measure to prevent spread of trachoma infections. Antibodies. Use of antibodies constitute the secondary prevention against trachoma. The antibody therapy in endemic areas are as follows. Oral azithromycin should be administered to all community members. Tetracycline eye ointment twice daily for 6 weeks. Mass antibiotic therapy should be given once in a year for continuous 3 years. Reassessment of prevalence should be made after 3 years. And annual treatment should be continued till TF prevalence in 1 to 9 years children. In areas with prevalence between more than 5 and less than 10%, targeted antibiotic therapy is recommended only among family members, close contacts of patients. In areas with prevalence less than 5%, treatment of patient only is recommended. Surgery. Who recommends bilateral tarsal rotation surgery at community level for affected persons? Now let's see what viral conjunctivitis. Most of the viral infection tend to affect the epithelium both of the conjunctiva and cornea. So it is called keratoconjunctivitis, both cornea and conjunctiva. In some viral infection, conjunctival involvement is more prominent. Pharyngoconjunctival and in others cornea is involved. Herpes simplex. Viral infections of conjunctiva include adenoconjunctivitis, herpes simplex, keratoconjunctivitis, herpes zoster conjunctivitis, molluscum contagium conjunctivitis, pox virus conjunctivitis, myxovirus conjunctivitis, paramyxovirus conjunctivitis, arbor virus conjunctivitis. Clinical presentation of acute viral conjunctivitis include acute follicular conjunctivitis and acute hemorrhagic conjunctivitis. Adenoviral conjunctivitis. Adenovirus, it is caused by adenovirus. These are non-enveloped double-stranded virus. Types of adenoviral conjunctivitis include epidemic keratoconjunctivitis (EKC), non-specific acute follicular conjunctivitis, pharyngoconjunctival fever, chronic relaxing adenoviral conjunctivitis (EKC). Epidemic keratoconjunctivitis, it is a type of acute follicular conjunctivitis mostly associated with superficial punctate keratitis and usually occurs in epidemics, hence the name EKC. Etiology. It is caused by type 8, type 19 adenovirus. It is most contagion, spreads through contact with contaminated fingers, solution tonometers. Clinical features. Incubation period after infection is about 8 days and the virus is set from inflamed eye for 2 to 3 weeks. Symptoms are similar to severe form of acute keratoconjunctivitis conjunctivitis, include redness of sudden onset associated with watering, usually profuse with mild mucoid discharge, ocular discomfort and foreign body sensation. Photophobia, usually mild, becomes marked when cornea is involved. Redness, ocular discomfort and photophobia. Signs. Conjunctival signs. Hyperemia, chemosis of conjunctiva is usually present. Follicles of small to moderate size typically involved. The lower fornix, palpable conjunctiva form the characteristic feature. Acute follicular adenoviral conjunctivitis. Hyperemia, chemosis, follicles of small to medium size. Pseudomembrane petechial subconjugal hemorrhage in acute epidemic keratoconjunctivitis. Papillary reaction may also be seen in many cases. Petechial subconjunctival hemorrhages may be seen in severe adenoviral conjunctivitis. Pseudomembrane lining the lower fornix and palpebral conjunctiva may be formed in about 3% of the severe inflamed conditions in this patient. Corneal involvement occurs in about 80% of the cases and is characterized by following lesions: epithelial microcystic diffuse fine non-staining lesions, superficial punctate keratitis (SPK), a typical feature of EKC, usually occurs after 10 days of onset of symptoms and lasts for 3 weeks. Corneal involvement is a corneal signs, and subepithelial infiltrates may develop under the focal epithelial lesions in 20 to 50% of cases. These opacities may be initially disabling and may persist for months to years. Pre-auricular lymphadenopathy is also associated with almost all cases of EKC. Differential diagnosis: epidemic keratoconjunctivitis need to be differentiated from other causes of acute follicular conjunctivitis, which include differential diagnosis: acute hemorrhagic conjunctivitis, herpes simplex virus conjunctivitis, other types of adenovirus keratoconjunctivitis, adult inclusion conjunctivitis, etc. Differentiation is made from typical clinical features described earlier. Investigations are required mainly for research purpose and in some non-resolving cases, and include conjunctival cytology, with gemstone staining shows predominantly mononuclear cells in adenoviral conjunctivitis, mononuclear cell infiltrations, and multinuclear giant cells in herpes conjunctivitis. Polymerase chain reaction test is sensitive and specific for viral DNA. Point of care immunochromatography test takes only 10 minutes to detect adenoviral antigens in tears, have excellent sensitivity and specificity. Viral cultures are tedious and time consuming with variable sensitivity but 100% specific. Treatment: supportive treatment, cold compress, sunglasses, decongestion, lubricant teardrops to decrease discomfort, etc. Topical antibiotics, topical antiviral drugs are not beneficial in adenoviral conjunctivitis. Recently, promising results are reported with adenine arabinoside. Topical steroids should be used during active inflammation, as these may enhance viral replication and extend the period of infectivity. Weak steroids such as fluoromethanol, low T-prednol are indicated in patients with subepithelial infiltrates and in those with membrane formation. Prevention of spread of infection to contacts. It is most important as the adenoviral conjunctivitis is highly contagious and patients may be infected for up to 11 days after onset. Transmission usually occurs from eye to fingers to eyes. Tonometers, contact lenses, etc. can also cause transmission. Preventive measures: frequent hand washing, avoid rubbing, relative isolation of infected individual, common use of towel and handkerchief should be avoided. Disinfection of ophthalmic instruments. Non-specific acute follicular conjunctivitis. Most common form of acute follicular conjunctivitis caused by adenovirus serotypes 1 to 11, 19. Clinical features are of milder form of acute follicular conjunctivitis. Corneal involvement is not known. Treatment and preventive measures are similar to as described for EKC. Pharyngoconjunctival fever. It is an adenoviral infection commonly associated with subtypes 3 and 7. Clinical feature: pharyngoconjunctival fever primarily affects children appears in epidemic form. It is characterized by an acute follicular conjunctivitis associated with pharyngitis, fever and pre-auricular lymphadenopathy, corneal involvement in form of superficial punctate keratitis. Treatment is usually supportive as described in EKC. Newcastle conjunctivitis. It is also a type of acute follicular conjunctivitis caused by Newcastle virus. Infection contact from owl. Acute herpetic conjunctivitis. Primary. It is accompaniment of primary herpetic infection, which may occur in children. Etiology: caused by herpes simplex virus 1 and specific kissing or close contact. Maybe herpes simplex virus 2 also can involve, but it's not known. Clinical feature: acute herpes acute herpetic follicular conjunctivitis is usually a unilateral affection with an incubation period of 3 to 10 days. It may occur in two clinical forms, typical and atypical. Typical form: the follicular conjunctivitis is usually associated with other lesions of primary infection such as vesicular lesions of face and lids. Atypical form: the follicular conjunctivitis occurs without lesions of face, eyelid, and conditions then resemble epidemic keratoconjunctivitis. The condition may evolve through phases of non-specific hyperemia, follicular hyperplasia, and pseudomembrane involvement. Corneal involvement, though rare, is not uncommon in primary herpes. It may be in form of fine or coarse epithelial keratitis, typical dendritic keratitis. Preauricular lymphadenopathy occurs almost always. Treatment: primary hepatic infection is usually self-limiting. Topical antiviral should be given. Supportive measures are similar to EKC. Acute hemorrhagic conjunctivitis. It's an acute inflammation of conjunctiva characterized by multiple congenital hemorrhages, congenital hyperemia, mild follicular hyperplasia. 3 conditions. Etiology: it's caused by picornavirus, and it is very contagious and transmitted hand to eye contact. Clinical features: epidemic hemorrhagic conjunctivitis has been suggested in East. It's an epidemic form in East Africa and England. Incubation period of ESC, epidemic hemorrhagic conjunctivitis, is very short, 1 to 2 days. Symptoms include pain, redness, watering, photophobia, mild photophobia, transient blurring of vision, lid swelling, etc. Signs of EHC, acute hemorrhagic conjunctivitis, EHC. Signs of EHC are congenital congestion, chemosis, multiple hemorrhages in bulbar conjunctiva, mild follicular hyperplasia, lid edema, preauricular lymphadenopathy, etc. Corneal involvement may occur in the form of fine epithelial keratitis. Treatment: EHC is very infectious, poses major potential problems of cross infection. Prophylactic measures are very important and are same as EKC. No specific effective curative treatment is known. However, broad spectrum antibody eye drops may be used to prevent secondary bacterial infection. Usually, disease has self-limiting course of 7 days. Ophthalmia neonatorum. It is the name given to bilateral inflammation conjunctiva occurring in an infant less than 30 days old. It's occur in infants. As a matter of fact, any discharge or even watering from eyes in the first week of life should arouse suspicion of ophthalmia neonatorum, as tears are not formed till then. It's very important. Etiology: source and mode of infection. Infection may occur in 3 ways: before birth, during birth, after birth. Before birth, infection very rare through infected liquor amni in mothers with ruptured membranes. During birth, it is most common mode of infection from infected birth canal, especially when child is born with face presentation or with forceps. After birth, infection may occur during first bath of newborn or from soiled cloth or fingers from infideloquia. Causative organism: chemical conjunctivitis. It is caused by silver nitrate or antibodies used for prophylaxis. Gonococcal infection was considered serious disease in past, as it is responsible for 50% of blindness in children. But recently, the decline in incidence of gonorrhea as well as effective methods of prophylaxis and treatment have almost eliminated it in developed countries. However, in many developing countries, it still continues to be a major problem. Other bacterial infection responsible for ophthalmic neonatorum are Staphylococcus aureus, Streptococcus hemolyticus, Streptococcus pneumoniae, etc. Chlamydia trachomatis is also responsible. Herpes simplex ophthalmia neonatorum is a rare condition caused by HSV2. Clinical features: it varies. The causative agent, incubation period. Incubation period varies depending on the causative agent. Chemical occurs in 6 hours. Neonatal inclusion conjunctiva occurs in 21 days and respectively. Symptoms: pain and tenderness in eyeball, conjunctival discharge. It's a purulent discharge in gonococcal ophthalmic neonatum, or mucoid and mucopurulent in bacterial cases, and neonatal inclusion conjunctivitis. Lids are usually swollen in infected cases. Eyelids and periocular vessels may occur in HSV infection. Conjunctiva may show hyperemia and chemosis. There might be mild papillary response in neonatal inclusion conjunctivitis and herpes simplex ophthalmic neonatum. Corneal involvement, though rare, may occur in form of superficial punctate keratitis, especially in herpes simplex ophthalmic neonatum. Complication: untreated cases, especially of gonococcal ophthalmic neonatum, may develop corneal ulceration, which may perforate rapidly, resulting in corneal opacification or staphyloma formation. Treatment prophylaxis needs antenatal, natal, and postnatal care. Antenatal includes thorough care of mother, treatment of genital infection when suspected. Natal measures are of utmost importance as most infection occurs during childbirth. Delivery should be conducted under hygienic condition, taking all aseptic measures. The newborn baby closed lids should be thoroughly cleansed and dried. Postnatal measures include povidone iodine, 1% tetracycline ointment, etc., erythromycin ointment, etc. Single injection of ceftriaxone should be given, and the dose is also should be 125 mg and it should not exceed. And curative treatment. As a rule, congenital cytology examples, culture sensitive swabs should be taken before starting the treatment. Chemical ophthalmia is a self-limiting, it will recover on its own. Gonococcal ophthalmia neonatal needs prompt treatment. Topical therapy should include saline lavage, hardly till the discharge is eliminated. Bestracin ointment. Bestracin eye ointment 4 times a day. Because of resistant strains, topical penicillin therapy is not reliable. Penicillin drops 5000 to 10,000 units per ml should be instilled every minute for half an hour. If cornea is involved, atropine sulfate ointment should be given. Systemic therapy. Neonates with gonococcal ophthalmia should be treated 7 days with one regime of following: ceftriaxone, cefotaxime, ciprofloxacin, etc., norfloxacin, etc. If the gonococcal isolate is proved to be susceptible to penicillin, crystalline benzyl penicillin G50,000 units to full term. Normal weight babies 20,000 units premature, given for 3 days. Other bacterial ophthalmic neonatal should be treated 2 weeks with broad spectrum antibody drops, ointments such as neomycin, bestracin, and tropramycin. Neonatal inclusion conjunctivitis respond well to topical tetracycline 1%, erythromycin 0.5% ointment QID for 3 weeks. However, systemic erythromycin should also be given since presence of chlamydia agents in conjunctiva implies colonization of upper respiratory tract as well. Herpes simplex conjunctivitis is usually a self-limiting condition. However, topical antiviral drugs control the infection more effectively than and may prevent the recurrence. High-dose intravenous acyclovir is indicated in cases suspect of systemic herpes infection. Granulomatous congenital inflammation. Common are tuberculosis, sarcoidosis, syphilitic, leprotic, conjunctival, in tularemia, ophthalmia nodosa, etc. Perinods. It's given to group of symptoms: periapical lymphadenopathy, fever, unilateral granulomatous conjunctivitis. Common causes are tularemia,